with AGRS Championship Session. This session is for the six best selected abstract. Well, our presenters will be presenting. This session is chaired by Dr. Garima. Please come on to the dais. Dr. Seema Wadhwa, please come on to the dais. The session will be judged by 3 judges. Dr. Sabita, ma'am, please come in the front. Have a seat. Dr. Arnold, sir, please come in the front, sir. Dr. Punita, ma'am, please come. The presenter will get 6 minutes of time for presentation and a minute of time for the judgment. The first presenter is our Dr. Rohit Raina. He'll be presenting on pregnancy outcome following robotic-assisted laparoscopic myomectomy, 10 years experience.
Okay. The timing slots. Okay. Okay. A very good morning to all of you. I thank AGRS for giving me this wonderful platform. I present to you our pregnancy outcomes following robotic-assisted laparoscopic myomectomy at 10-year experience. So what we do for the myomectomy, the gold standard treatment for the symptomatic fibroids with the patients desirous of fertility preservation. Robotic-assisted surgery has been seen a rapid development with an integration in the field of gynecology, considering its several advantages over the conventional laparoscopy. However, limited data is available describing the fertility outcomes after RALM. Various studies have shown a wide range of pregnancy rates after the RALM, ranging from 33% to 77.8%. Our aim in this study is to study the pregnancy outcomes after robotic-assisted laparoscopic myomectomy. It was a single-center study, a retrospective observational study. The patients who underwent RALM for fertility enhancement from a duration of August 12, 2012 to May 23 in the Department of Gynecology under the care of a single surgeon. And we wanted to know the fertility outcomes. So the RALM was performed using the Da Vinci SI and XI system. In both the surgical systems, we followed our 2-arm, 3-instrument techniques, where we used a curved monopolar scissors, bipolar fenestrated forceps, and a mega needle holder for suturing. A 5 mm assistant port was used for the assistance. We used the Rumi's uterine manipulator. The suturing was done using a V-lock number 0 in multi-layer. No adhesion prevention barrier was used. The myoma was retrieved using a cold knife morcellation. So post the surgery, the patients were advised for conception after 6 months. The patients who conceived both spontaneously and by IVF were studied in this study. So a total of 243 cases of robotic-assisted laparoscopic myomectomy were studied. 114 were operated for fertility enhancement. We had 21 patients who were lost to follow-up and 7 were not in a conception period. So a total of 86 patients were analyzed for the reproductive outcome, out of which 54 were for the primary infertility and 32 were in the secondary infertility cases. So the mean age, what we saw for the study was 31.99. Mean BMI was 27.60. The fibroid weight was 347.83 grams. And the most common location that we found was the anterior wall, 41.9%. The most common FIGO type we saw was the FIGO 4 with the 36% and a FIGO 5 that was with the 33.7%. The mean number of fibroids that we removed was 2.10. The endometrial breach was observed in 13.15 cases. The mean blood loss was around 110 and mean operative time was around 147 minutes. The fertility outcomes, all cases were delivered by cesarean section. The 69% got delivered at 37 to 38 weeks. 27.9 delivered at 36 weeks due to the associated comorbidity, the PIH, obstetric cholestasis, and GDM. 2 cases, we had a twin pregnancy done by the IVF, they got delivered at 35 weeks. 3 of our cases got delivered second time. In our study, we found no uterine rupture. So there was no statistical difference was found in the number of fibroids removed, the size and the position of fibroids with the pregnancy outcome. None of the myoma characteristics were related to the spontaneous abortion. So pregnancy rate was 74, just is going out. Yeah, this slide got missed. The mean time to conception in our study was 14.62 months. The spontaneous conception rate was around 56.97. We had a 6 abortion for the spontaneous conception. IVF, it was 43.02%, which we saw 5 cases of abortion and 2 failed IVFs. So abortion rate was seen around 12.79. So our fertility outcome, the pregnancy rate was seen as 86.04% and the live birth rate was seen of around 73.25%. So this is just a comparison to show how our study is going with the other rates, other studies. You can see the pregnancy rates of 86.04 in this part, and a live birth rate of a 73.25%, which is comparable to rest of the all the other studies which have happened. Our study is a recent one, a pilot study kind of, we can say it in the India. None of the robotic surgery experience has been given with the fertility outcomes. So in conclusion, the pregnancy rate of 86.04 was seen with a very low incidence of complication. So we can consider it realm as an effective method for fertility enhancement. Thank you. Okay.
Thank you for the nice presentation.
Welcome.
And questions judges will ask.
Very nice presentation.
Thank you.
Couple of quick questions.
Yes.
You didn't mention anything about preoperative imaging. What was your modality for?
The preoperative, we did have MRI, and in some cases after the exercise system or recently we started doing the 3D imaging, the 3D model formation for the myoma mapping.
And then the other question I have is, what was your sort of recurrence reoperation rate on your patients? Were you able to track that?
For the reproductive outcome group, we didn't have any reoperation rate.
So none of those patients that conceived during that 10-year interval needed to have a re-op at some point?
No. We told the patients to get conceived after 6 months, and the mean conception time is around 14 months.
You mentioned the spontaneous conception rate.
Yes.
Would you consider the other factors for infertility and age?
Yes.
This apart from just doing
Yes.
a myomectomy?
The infertility is a complex thing as of now. So you will never get a concise or a straightway answer for the infertility. The myoma is just a part of that. We had a very, the mean age group, what we had in our study was a very young group. So we consider that that also added up in our study for a very good reproductive outcome.
Another question is that you allowed them to get pregnant after 6 months.
Yes.
That was blanket for all, or did it vary with the breach of endometrium or other complexities associated with the surgery?
No, we just told them to get conceived after 6 months. There was no, in our study also, we didn't find any relation with the endometrial breach happening with the spontaneous abortion rate or the pregnancy rates.
Right.
So no relation was found.
And all cases were blanket cesareans?
Yes, yes.
Okay.
So just a question. Why did you choose 6 months period?
As such, there are no guidelines, straightway guidelines. It was earlier said 12 months to go for the reproductive procedure. But the robotic platform that gives you the superior uterine reconstruction, the uterine reconstruction is so perfect. there is very less chance of the uterine rupture. In our study also, we didn't found any uterine rupture.
Come across any literature saying that you can conceive even earlier on?
There are few case reports, but no guideline is there and nothing is there.
So just
Hello.
one other quick question.
Yeah.
Did you look at any other secondary outcomes in terms of, I don't recollect seeing where you talked about like what their bleeding profiles were and whether you looked at like quality of life indicators.
Sorry
Yes,
to
the
interrupt,
quality
sir.
but we haven't included this in this. The patients got, we are a tertiary center and we got.
Yeah, sorry to interrupt, sir. Presentation 6 minutes and discussion for 2 minutes.
Oh.
We'll confine the time, please. Thank you so much. Thank you, Dr. Rohit.
Yeah,
Thank you so much.
Thank you.
We'll call next our speaker, Dr. Anupama Bahadur. Her study is on comparing the outcome of enhanced recovery after surgery and tradition. Hello. Ma'am, are you ready? Just go. एक मिनट, मैं रखती हूँ. नहीं. I request upon again the presenter to confine to the time and judging 2 minutes. We inform Dr. Maumita, the next speaker, to be ready.
A very good morning to our respected judges as well as the audience. So my study was comparing the outcome of enhanced recovery after surgery, that is AGRS, and the traditional recovery pathway in robotic hysterectomy for benign indications. This was a randomized controlled trial in the Department of Obs and Gynae at AIIMS Rishikesh. So, well, these are my mentors, and the study would be incomplete without mentioning Dr. Anshu Bala Kulkarni, Dr. Ruma Sinha, and Dr. Anupama. AGRS, it is a multidisciplinary approach comprehensively designed to improve the post-op outcome, and it was Dutch professor Henry Kellett who challenged the traditional paradigms which are not evidence-based of perioperative care. And he gave the concept way back in 1997 of a multimodal approach to control post-op pathology and rehabilitation. So it was colorectal surgery. They were the first subspecialty where AGRS pathway was implemented in the year 1999. And it was surgeons who met 2 decades back in London to develop the guidelines for perioperative care based on evidence. They use the other terms like rapid recovery program, multimodal perioperative management or fast track program, and it is a multidisciplinary approach involving the surgeons, the anesthetists, the nursing staff who are caring for the patient. There is limited data on the effectiveness of AGRS program in gynae procedures, especially benign surgeries. There's plenty available on malignant. So the stress is that key pathogenic factor resulting in post-operative morbidity has encouraged development of the rapid recovery pathway. The techniques for early recovery include patient counseling, reducing the preoperative fasting, adequate analgesia and anti-emesis, early ambulation, early feeding, anti-thrombotic and antimicrobial prophylaxis, whereas the traditional practices that are being followed are encouraging the use of drains, nasogastric tubes, catheters, restriction of oral intake and ambulation, and there is no scientific proof for supporting such a practice. So with this, the aims and objectives of our study was to investigate the applicability of AGRS protocol versus the conventional in robotic gynae surgery for benign indication and its influence on the post-operative length of stay. So our primary objective was to compare the post-operative median length of stay in the hospital between the 2 groups. Fit for discharge was the criteria that was used to assess the length of stay, because as they come from a hilly terrain where they don't go back after stitched before stitch removal, and it is a cultural practice where, sending them back would probably hurt their sentiments. So with limited transport in the hilly terrain, the facilities for staying back a longer duration, we cannot deny. Our secondary objective was to evaluate and compare the role of ERAs in time to tolerance of diet, time to passage of flatus or defecation, post-op recovery and its complication and readmission within 30 days of discharge. So this was a randomized control trial in the Department of Obs and Gynae. 130 eligible participants who underwent robotic hysterectomy for benign indications between July 2021 to March 2023. The sample size was calculated, and assuming a power of 80% and 95% confidence interval, we calculated a sample size for each arm of 65. It was approved by the Institute Ethics Committee, and a CTRI number has been obtained. So the patients, they were randomized by block randomization, and the inclusion criteria were patients who were between 40 to 65 years of age, ASA 1 and 2, and they were mainly for benign disorders, and they were willing to give their consent and willing to participate in the study. Exclusion criteria, however, were any medical disorders, patient not willing to... Oh my God. Okay, so we followed the ERAS pathway, and you can see the patient's recovery. So when we compared the duration of hospital stay and fit to discharge, as you can see, all were statistically significant, and especially in the ERAS, the time to tolerance to solid diet, passage of flatus or defecation were all significant, statistically significant, as well as removal of Foley's catheter, times to sit and time to ambulate. So the conventional approach is without any scientific basis, and the ERAS is definitely better in comparison to the conventional report. So with this, we intended to find the basis of this result with respect to the benign gynae surgeries, and also it was an opportunity to introduce ERAS into the routine perioperative care. So these are some of the studies that have been published in literature, which are similar to ours. The main strength of the study was that being a randomized controlled trial, there was good adherence to the protocol. It's the first RCT in robotic as far as we have searched the literature in India, and exclusively for benign indication. But our limitations are, of course, the small sample size. We need prospective multicentric randomized control trial with larger sample size, and also to assess the feasibility of ERAs in women from low resource settings before generalizing the findings of the study. Thank you.
Very nice presentation as well. Couple of questions. I didn't pick up because you were flipping through quickly. In terms of, did you utilize any particular type of medications as part of your ERAS protocol?
So we followed, I skipped those slides because of lack of time. So bowel preparation, we used tinidazole 2 grams HS a day prior to surgery. And preoperatively, solid food was allowed up to 6 to 8 hours before the surgery. Clear fluids up to 2 hours before surgery, and carbohydrate-rich fluid, that is 50 grams glucose, in 200 ml water 4 hours prior to surgery. So the normal ERAS that is usually followed, we followed that.
But did you give any medications? Like, so for example, like in our ERAS protocols in our hospital, we utilize things like, gabapentin, neuromodulators, non-steroidals. We give Tylenol. We give, things like that ahead of time for patients before they go in for anesthesia.
No, we didn't do that.
Okay.
Another thing is, I think with the ERAS, you need to know what happened during the surgery. The expertise, the kind of dissection, the extent of dissection also influences your post-op, apart from counseling.
It was a single surgeon
Yeah.
doing the surgeries.
Yes.
So we took benign cases, I think. We kept it simple because, it was a randomized control trial, and thank you.
Yeah, I think good results also, and you were happy with the results. Is it so?
We were.
All right.
And we are following it as a routine standard of care now in our day-to-day practice.
And then only other question I have is, I didn't see it in your results, but did you track the pain the narcotic
We did.
utilization in terms of like morphine equivalents?
We did. We looked at that as well, but I did probably put this slide.
Thank you, Dr.
Thank you.
Anupama Bahadur, for presenting. We call upon our next speaker, Dr. Momita. This is the last speaker for a benign session.
Very good morning to everyone. Yeah, this is Dr. Momita, and I am presenting Beyond the Learning Curve, Improving Outcomes in Robotic Myomectomy compared to Laparoscopic Myomectomy. Uterine myomas are benign tumors frequently seen in the reproductive age group, and as per the Global Burden of Disease 2019 data, the prevalence is increased from 1990 to 2019, and current growth rate is 78.82%, and in India it is 0.90% per year. And the age group affected 25 to 29 years to 45 to 49 years, with the highest trend in the 35 to 39 age group. Myomectomy remains a viable option for treating this condition in women who wish to preserve their fertility, and the gold standard is minimally invasive surgery, both laparoscopic and robotic. And we believe that robotic assistance can help and bridge the gap and make the minimally accessed myomectomy accessible and adaptable to the larger population. So to our aim is to compare beyond the learning curve the outcome of robotic myomectomy versus laparoscopic myomectomy. We have retrospectively reviewed our patient data from 2015 to 2021, and who underwent laparoscopic myomectomy and robotic myomectomy for the treatment of their uterine myomas. And robotic myomectomy, to perform, we used the Da Vinci SI with multi-port technique with 12mm camera port, 8mm ancillary ports, and 5mm assistant port. Inclusion of 30-degree telescope, hot shearers, fenestrated bipolar, mega needle holder to perform the surgery with 2-arm 3-instrument technique. And for the laparoscopic myomectomy, we have used the STOTS with standard 2D vision with central 10mm port, ancillary 5mm ports, and if necessary a 5mm right side port, ancillary ports mostly on the left side, with 30-degree laparoscope, harmonic scalpel, scissors, myoma screw, and needle driver. Reconstruction purpose, we have used both the arms V-lock number 0 sutures. We have recorded all the demographic data from patient medical records, symptoms, and the indications are also recorded. Diameter, number, weight, total of the removed myomas, operative time, blood loss, length of stay, transfusion need, and requirement of post-op IV analgesia were recorded. Total operative time included from the placement of ports to the closure of the ports. And all surgeries are done by a single experienced surgeon. Total 177 patients included, out of that 116 patients in robotic myomectomy group and 61 patients in laparoscopic myomectomy group. And our study shows the mean BMI is high in the robotic myomectomy group with 27.35 kg per meter square. Mean number of fibroids removed were more in the robotic myomectomy group, which is comparable to the other studies in literature. And the mean size of the largest fibroid for our study, it is 9.13 centimeter, which is much bigger than the comparable studies. And the mean fibroid weight, it is around, it is also high, 382 gram in the robotic myomectomy group and 418 in laparoscopic myomectomy group. So all over, the robotic assisted surgery is useful in performing more complex myomectomies. Our docking time is 6.73 minutes and console time of 93 minutes. Total operative time, if we see that it is not, it is little more than the laparoscopic myomectomy group, 127 minutes in robotic myomectomy versus 120 minutes. Though it is not, p-value is not significant, but still it is an important finding. And the blood loss is much less in the robotic myomectomy group, which is very much significant, and the length of stay is also significant. It is very less. So there is, as we can see this in chart, there is no need of blood transfusion requirement in robotic myomectomy group, around 93% of cases. Our mean operative time, total operative, as I mentioned before, yeah, it is slightly high, and which is important finding, and that contradict the previously higher operative time limits. And IV analgesia requirement is also very less. So we have done multiple regression analysis and also the stepwise analysis to see the comparable independent variables and their importance on the length of the study, whether there is any impact, and we got it is a higher power with a significance. Yes, it is affected, and the most important indicator, type of the number of fibroids and the size of fibroid. Type of surgery doesn't make any impact on that. So our conclusion is, yes, robotic myomectomy significantly reduced the blood loss, length of stay, requirement of blood transfusion, and there is a 72 hours post-operative analgesia requirement is there, and that may be the need of the early discharge. So beyond the learning curve, though it is, robotic myomectomy is comparable, not better than laparoscopic myomectomy in clinical practice. Thank you.
Also, very nice presentation.
Thank you, sir.
The question I have for you is, I didn't see anywhere where you had defined what the completion of the learning curve was. So for this single surgeon, what defined completing the learning curve for their robotics as well as for their lap? Like, how many procedures had they done in their career historically to say that they've completed that?
As per the studies available in the literature as of now, it is 50 cases are there to maturation stage of to get the learning curve. Yes, a learning curve is having 3 stages. The beginning stage, it is around 15 to 16 cases, and after the stabilizing phase is coming, there 16 to 25 cases are 25 onwards cases are there, and definitely 50 to 60 cases are to after that to get the maturation phase. So after that, definitely beyond the learning curve things are coming.
So how did you decide which cases to do robotically and which laparoscopically?
Yeah, we have given the options to the patient depending upon their clinical symptoms, their requirements, fertility requirements, and then patient is solely the person who is deciding on which she wants to go.
No surgical bias, surgeon bias?
No.
No surgeon
You
bias.
said the BMI for the robotic cases was higher. Was it like chosen by you, or was it?
No, it just came
just
in our
coincidence?
statistical analysis that yes, it is towards the
But
robotic
would you-
myomectomy group, it is high.
I think you have an excellent robotic team because the time frame of robotics and laparoscopy is almost similar,
Yes, and that is,
despite the fact that robotically you were taking up more complex cases.
that's what we want to tell.
Yeah, very nice study. Must
Yeah.
compliment you.
Yeah.
In your robotic group, the blood loss was almost 50%
Yeah.
as compared to the laparoscope. What do you
Yeah.
think? What is the reason?
Might be our total, all our lots of experience of over the periods, and definitely the patient selection, and that can be the reason, and the patient good hemoglobin might be.
Thank you, Dr. Momita.
Yeah, thank you.
I sincerely
Very good
thank,
presentation. Very
Yeah.
nice.
I sincerely thank our judges, so Dr. Sabita, Dr. Arnal, and Dr. Punita for judging this session on benign gynecology. And we are going to go on with our malignant session now, and I'll be calling upon Dr. Yogesh, Dr. Joseph, and Dr. Park. I request the judges to please come and sit in the front row. And Dr. Garima and Dr. Seema Madam will continue to chair the session. Requesting all the judges to come in the front, please. I'll be calling the speaker, Dr. Vandana Jain.
So good morning, everyone. So I'll be presenting my data on salvage robotic anterior pelvic exentration for cervical cancer, the technique and feasibility. So we all know concurrent chemoradiation is a standard evidence-based practice for locally advanced cervical cancer, but it is associated with a 5-year local failure rate of around 18 to 30%. These cases are very challenging to treat in the sense the re-irradiation of a previously irradiated field is very difficult and is relatively contraindicated, and chemotherapy does not reach the already fibrosed and devascularized tissue. So in such cases, performing a pelvic exentration is the only hope. Robotic-assisted PE allows a surgeon to work in the narrow confines of the pelvis. It is associated with a faster learning curve, 3D binocular ergonomics, tremor filtration, and 360-degree motion of robotic wrists, all of which allow the surgeons to perform such complex surgeries with ease without getting fatigued. So the aim of our study was to evaluate the feasibility and safety of robotic anterior PE in cases of residual or recurrent cervical cancer as a salvage therapy. So a retrospective analysis of 14 cases who underwent salvage robotic anterior pelvic exentration at our institute from January 2013 to December 2019 was done. The recurrent disease was confirmed by a preoperative biopsy. A PET MRI was done in all the cases to rule out distant metastasis and intra-abdominal disease and to determine the extent of pelvic disease to analyze the possibility of complete tumor removal. Patients with central pelvic disease who were physically and psychologically fit and understood the morbidity and consequent alterations in the body image were planned for this ultra-radical procedure after taking an informed consent from patient and family members. Pelvic exentration with curative intent was offered to patients with involved pelvic nodes if they were not bulky or conglomerate or adherent to the iliac vessels. Paraortic lymph node involvement was considered as a metastatic disease, and these patients were not offered curative PE. So we collected all the data pertaining to patient characteristics, details of initial treatment, perioperative outcomes, histopathological reports, and data on recurrence and survival. So coming to the procedure, the procedures were done with the XI robot with side docking, and combined regional and GA was administered. Patients were placed in modified Lloyd-Davis position. Total of 6 ports were placed. A 12 mm port was placed 2 fingers above the umbilicus for the camera. 2 8 mm robotic ports were placed 8 cm to the right and 8 cm to the left of the camera port at infra-umbilical line to accept the monopolar scissors and bipolar forceps respectively. Another 8 mm robotic port was placed on left side at a distance of 8 cm from the previously placed left robotic port at infra-umbilical line to accommodate the progress forceps. A 12 mm assistant port was placed 2 inches above the right anterior superior iliac spine, and another 5 mm assistant port was placed 2 inches cranial to both the camera port and the right-sided robotic port. A diagnostic laparoscopy was performed in all the cases after placing the camera to rule out extrapelvic metastasis and pelvic sidewall disease. So the procedure began by opening the retroperitoneum and identifying the bilateral ureters. This was followed by creating the bilateral pararectal and paravesical spaces. The IP ligaments were coagulated and cut, and then the anterior division of internal iliac artery was clipped and cut on both the sides. The round ligaments were cut at lateral pelvic wall. Ureters were cut after keeping appropriate length for anastomosis later on. Rectum was dissected off posteriorly from the cervix and vagina, and the uterosacral ligaments and cardinal ligaments were coagulated and cut at the level of sacrum and lateral pelvic wall, respectively. The dissection proceeded caudally till the levator muscles and endopelvic fascia over it was incised. Anteriorly, the bladder was separated from the pubic symphysis, entering the space of Retzius. Dissection continued caudally when the dorsal venous plexus of clitoris was coagulated and the bladder neck and urethra was excised completely. A colpotomy was performed circumferentially, and the entire specimen was delivered out vaginally, and the residual vaginal cuff was sutured. So this is just a pictorial depiction of the main steps of the robotic anterior exentration. Coming to the results, a total of 18 patients were found eligible for robotic anterior exentration based on examination and imaging findings. However, 2 patients were found to have pelvic sidewall disease and 2 patients were found to have disseminated peritoneal disease at initial laparoscopy, and hence the procedure was aborted in these cases. The mean time to exentration after completing the initial treatment was 14 months. The median console time was 133 minutes and the median EBL was 135 ml. Transverse colon conduit was made in 1 patient and alleal in the rest. None of the patients had any intraoperative complication as there was no conversion. The median duration of hospital stay was 6.5 days. Early complication within 30 days of surgery occurred in 5 patients, that is 36% patients. Mild intestinal ileus in 1, uretroileal anastomotic leak in 1, SAIO in 1, urosepsis in 1, and RVF in 1. The patient with RVF required a transverse loop colostomy. Rest were managed conservatively. Late complication after 30 days of surgery occurred in 43% patients. Bleeding from ileal conduit in 1, recurrent UTI in 1. Sigmoid perforation due to stercoral ulcer, not associated with disease in 1. Closed loop obstruction of sigmoid in 1 patient. Stenosis of uretroileal anastomosis in 1. And prolapsed stoma with cecal perforation associated with pelvic recurrence in 1. Over a median follow-up of 31 months, recurrence occurred in 5 patients and median time to recurrence was 6 months. Intraoperatively, one patient requires special mention. The patient had peritoneal disease in the form of few deposits on bladder and peritoneum and uterus and a small deposit on sigmoid mesentery. They were removed as a part of exenteration. Patient is alive and disease-free with a follow-up period of 22 months. 5-year mortality, for 5 patients experienced mortality with 4 deaths related to recurrence with a median time of recurrence after PE 12 months. Median DFS and OS were not reached for the cohort and the 12-month DFS was 68.2%. So median age was 52.5, median BMI 26.5. Initial stage was 2 in 1 patient, stage 2 and 3 in 4 patients. Squamous cell carcinoma histology in 13 patients. Initial treatment was definitive CCT-RT in 12, type 2 RH followed by adjuvant RT in 1, and simple hysterectomy followed by NSCT in 1. And the histopathological characteristics at the time of recurrence, size of tumor was 3.5 centimeter, LVSI present in 6 patients, paracervical tissue was positive in 3 patients. We could achieve negative margin in all the patients, and the bladder was tightly adherent in all the patients with the fat involved in 9, muscularis in 1, lamina in 1, and mucosa in 1 patient. Nodes were dissected in 7 patients and were positive in 2 patients. So this is just a snapshot of the complications, early and rate and recurrence. And so we have, like the data was compared with the retrospective data on open exenteration and other studies on robotic, and our findings very much corroborate with the findings of other studies. And there have been meta-analysis and they have compared open and robotic and laparoscopic and robotic, and they have found similar results. So thus concluding, robotic pelvic exenteration is feasible in selected patients with recurrent or residual cervical cancer post-chemoradiation without any adverse impact on oncological parameters, with acceptable morbidity and mortality. Careful selection of patients and maintenance of oncological principles is of utmost importance. Thank you.
So I had a quick question. Because we sped through the slides, can you just briefly outline your selection criteria for robotic pelvic exenteration?
So we had to see the patients who only had a central pelvic recurrence and they did not have any disseminated peritoneal disease or distant metastasis on imaging. And on finding on examination, it was a central disease with soft parametrium, and all the pelvic sides were free at least. We could take adequate margins. And the patient was informed that it will require a permanent stoma and body image changes will occur, and they are psychologically fit to understand the process and long-term application of bag and related changes. So, and they were told that even after that, recurrence can happen. It is not though it is done with a curative intent, still recurrences can happen.
Thank you for a really nice presentation and a nice series. It's only 12 patients at the end of the day, so 14 patients. So for future, I think, because your group is really mixed, you've got quite a lot of them that had CCRT prior, and then you had 2 patients that did not have any prior radiation, and I think that significantly changes the
only one
profile.
patient did not have prior radiation.
Yeah, thank you for a nice presentation. Among 14 patients, 1 patient did not receive the previous radiation therapy. In this patient, I think CCRT can be good treatment option. And how about the adjuvant therapy for node-positive cases after surgery?
Yeah. So though that patient had underwent surgery outside, the one who you're saying should have CCT-RT. So she just came to us with recurrence, and the node-positive patients we selected because the nodes were not bulky or conglomerate. So pelvic nodes we do take as a part of curative PE, but para-aortic nodes we don't take.
Sorry to interrupt. Time up. We'll call upon our next speaker.
Thank you.
Dr. Tarini, onto the dais.
Thank you, Dr. Vandana.
Good morning everyone, I am Dr. Tarini and the title of my study is Accuracy of Sentinel Lymph Node Biopsy in Predicting Nodal Metastasis and Endometrial Carcinoma at Tertiary Care Center Prospective Study. Endometrial carcinoma is the second most common cancer affecting women globally. The incidence increases annually 1 to 2%. Globocan 2020 has shown that annual incidence in India is 16,000 with annual death of around 6,000 and a five-year prevalence of 43,000 per 100,000 women. Surgical staging of nodal status is essential for determining the stage of the disease and developing a targeted treatment plan. To avoid the morbidities of lymphadenectomy, the use of sentinel lymph node biopsy has emerged as an alternative staging procedure. The aim of the study was to determine the detection rate and diagnostic accuracy of sentinel lymph node mapping and biopsy using ICG dye, an alternative to regional lymph node dissection in staging and managing endometrial cancer cases in terms of optimal technique, efficacy, safety, and post-operative morbidity. So ours was a prospective study conducted at the Department of Gynecological Oncology, Fortis Memorial Research Institute over a period of 2 years, September 2019 to September 2021, and included 50 patients. The inclusion criteria were patients with documented endometrial cancer on biopsy and clinically uterus-confined disease. Exclusion criteria included patients with evidence of extrauterine disease, those who had already undergone hysterectomy or treated for endometrial cancer like RT, CT, or hormonal therapy, having contraindications for receiving the ICG tracer, that is history of hepatic impairment or an iodine allergy. Methodology: complete demographic profile of patients was recorded after obtaining written informed consent. ICG tracer was injected into the cervix after anesthesia induction. A standardized dose of 0.25 mg per ml was created by diluting 0.4 ml of the stock solution into 3.6 ml of the sterile water. A 22-gauge needle was used to inject 1 ml of the ICG solution into the uterine cervix at 3 and 9 o'clock positions to a 2 to 3 mm and 1 cm depth, achieving a total dose of 1 mg. Da Vinci Xi system was used in all the patients. After obtaining peritoneal entry, fluorescence imaging was used to visualize the ICG tracer in the lymphatics. A successful mapping was defined by observing a channel leading from the cervix directly to at least one candidate lymph node in at least one hemipelvis. The identified sentinel lymph nodes were retrieved separately and labeled for location. Separate timings were noted for left and right sentinel lymph nodes. Following this, complete bilateral pelvic lymphadenectomy was done. Sentinel lymph nodes were not subjected to frozen section and were ultra-staged later by the pathologist. Adjuvant treatment was planned as per the ICCN guidelines. Perioperative morbidity was graded according to the Clavin-Dindo classification. This is the pictorial depiction of the sentinel lymph node and its excision. So coming to the results, the mean age in our study population was 60 years. 78% of the patients presented with postmenopausal bleeding. The mean BMI was 29.4. Out of which 34 patients were obese, 84% had hypertension, and 30% had diabetes. So in our study, 98% was the sentinel lymph node mapping rate, out of which 80% were mapped bilaterally and 20% unilaterally. There were none of the patients were allergic to ICG dye. The first mean sentinel lymph node detection time was 47 minutes, and the second mean sentinel lymph node detection time was 73 minutes. This was from the starting of the procedure. The mean number of pelvic lymph nodes were 17, and mean number of sentinel lymph nodes were 2. This is the graph showing the sentinel lymph node site distribution. The commonest site was the external iliac group, followed by internal iliac and obturator region. In our study, we could find that 2% each of the sentinel lymph nodes were mapped at the common iliac and low periaortic region. So 82% of the patients belonged to stage 1A disease, and only 4% had stage 3C1. 96% had endometrioid type of cancer and 4% had serous. 1% had grade 1 patient, 60% patient had grade 1 disease. Less than 50% myometrial invasion was seen in 88%, and LVSI was positive in 10%. In our study, out of 49 patients with sentinel lymph node mapping, 2 patients had positive lymph nodes on final histopathology. Of these 2 patients, 1 had a positive sentinel lymph node and 1 had a negative sentinel lymph nodes. The remaining 47 patients had both negative pelvic as well as sentinel lymph nodes. Therefore, the sensitivity was 50%, specificity of 100%, positive predictive value of 100%, negative predictive value of 97.9%, and the accuracy of 97.6%. The mean length of hospital stay was 2 days. All the patients were only allowed and discharged the next day. None of the patients had any intra-op or post-op complications, and all belonged to grade 1 of the Clavin-Dindo classification. These are some of the studies which have shown that the detection rate has ranged from 86 to 96% in sensitivity, from 84 to 100%. In our case, the two patients who had positive lymph nodes, the one case where sentinel lymph node was positive was 34, the patient was 34 years old with grade 2 disease. Tumor size was 2.5 centimeter with less than 50% myometrial invasion. Lower uterine segment and cervix were not involved. There was no LVSI and the metastatic focus was 2 millimeters. That is, it was a micrometastasis. And the patient who had negative sentinel lymph node and positive pelvic lymph node was 72 years of age with grade 2 disease. Tumor size was 7 centimeters with more than 50% myometrial invasion. Lower uterine segment and cervix were involved. LVSI was positive and it was a macrometastasis of 6 millimeters. So to conclude, sentinel lymph node biopsy by intraoperative cervical injection of ICG dye appears feasible with a high detection rate and accuracy in clinically uterus confined carcinoma endometrium. Thank you.
Thank you, Dr. Tarini. It was an excellent presentation. So I just wanted to ask, this was a study where you did sentinel node followed by pelvic lymph node dissection.
Yes, sir.
Yeah. So what was the mean number of sentinel nodes you have identified in two lymph nodes in each? And you were able to identify bilateral sentinel node in about 80% of patients. So in 20% of the patients, you would, in 18% you had unilateral identification.
Yes,
and
20%.
2 or 3% there was no. So what was the lag time, that you looked at when after injecting the dye to identify the sentinel nodes?
So the first node to be identified took around 45 minutes. And the second node, so it was right and left were separately timed. So the first node took around 45 minutes and the second around 72, 73 minutes.
Okay. And the second question I had is, in patients where you were not able to identify the sentinel node, have you tried, re-injecting the dye?
No, sir, we didn't.
Okay. Thank you.
Yeah, thank you for excellent outcome using sentinel lymph node mapping. You have one false negative case. In that case, what was sentinel lymph node and what was metastatic lymph nodes in this case? Important thing is, did you find both upper cervical pathway and lower cervical pathway in this false negative case?
Sorry, sir, I couldn't understand. The one patient that was sentinel lymph node negative.
Yeah.
So the lymph node was mapped bilaterally and it was external ilia group.
External group.
Yeah.
And what was a positive metastatic node? Where was the metastatic nodes?
The pelvic group, the external ilia group only, sir. It was there only.
Okay, in this case, did you identify upper cervical pathway and lower cervical pathway also?
It was a lower pathway, paracervical pathway. The lower paracervical pathway.
Thank you, Dr. Tarini. We'll call our last presenter, Dr. Saumini Banerjee, and our AGRS Championship session will be completing after the last presenter, and will followed by prize distribution.
Your laptop.
Minute. Very good morning to all respected judges, chairpersons, delegates, and my dear friends. My topic of presentation is validation of sentinel lymph node biopsy in high-risk endometrial carcinoma for Indian women. Introduction. Sentinel lymph node biopsy is widely accepted as a standard care for surgical staging in low-risk endometrial carcinoma. For high-risk cases, it is still controversial. Systemic lymphadenopathy is a recommended procedure for high-risk cases which is associated with significant morbidity like lymphedema, lymphocyst, injury to adjacent nerves and vessels. Whether sentinel lymph node can replace systemic lymphadenectomy in these cases still remains debatable. The aim was to determine negative predictive value, sensitivity, specificity of sentinel lymph node biopsy in Indian women with high-risk endometrial carcinoma. The design of study was prospective observational study. The period of study was March 2021 to February 2023, and sample size was 50. Methods: all surgeries were done on a robotic platform. Both sentinel lymph node biopsy and comprehensive lymphadenectomy were done in 50 patients with high-risk endometrial CA. MSKCC SLNB protocol was followed for both SLNB and ultrastaging. Here's a short video for you. We used an ICG dye, indocyanine green dye. We double dilated it at a rate of 2.5 mg per ml. We used a long needle and we injected it at 3 o'clock and 9 o'clock position in the cervix. We used a total of 4 ml of the dye, that is, we injected 1 ml deep and 1 ml superficial on each of the side of the cervical stroma. On inserting the camera, if we see this sort of picture, that metastatic disease, then we abandon the process. And if we see enlarged lymph nodes like this, we prefer removing all the enlarged lymph nodes along with the sentinel lymph node. Retroperitoneal lymph node dissection should be done meticulously without injuring the adjacent nerves and vessels. If there is no mapping on hemipelvis, we perform a site-specific lymph node dissection. On turning on infrared mode, near infrared mode in robotic, we will see a beautiful lymph channel along with the lymph nodes. Here we can see the obturator node, which is crossing the obturator nerve and running into the external iliac. We meticulously dissect the node, the sentinel lymph node, and send it for ultrastaging. Inclusion criteria: all women with presumed stage 1 and 2 of high-risk endometrial cancer were included. We use the previous FIGO staging for this. Exclusion criteria: stage 3 and 4 of high-risk endometrial carcinoma, patient with cardiorespiratory comorbidities and poor physical status who were deemed unfit for minimal invasive surgery, and patient who refused enrollment. Results: we have total of 50 patients, out of which bilateral mapping was seen in 43, that is 86% of patients. Unilateral mapping was seen in 7, that is 14% of the lot. Positive nodal mets were seen in 8. 1 turned out to be false negative, so a total of 9 total positive nodes. And we upstaged this to 3C. Of these 9 positive patients, 7 had positive pelvic node and 2 in lower para-aortic node. So we would have missed the lower para-aortic node if we have done only sentinel lymph nodes. Of the 6 had micromets and 2 had macromets. Concluding for my table, 8 were true positive, 1 was false negative, 41 true negative. So negative predictive value was depicted at 97.6% with a sensitivity of 88.89% and specificity of 100%. Concluding it, sentinel lymph node in high-risk endometrial cancer is safe and feasible for Indian women. High negative predictive value, that is only 2.5% chance of missing a nodal mets if you are doing sentinel lymph node only. And future prospective trials are required to replace comprehensive lymphadenectomy. I would like to thank you all for listening to my presentation patiently. A special thanks to Dr. Arunabha Roy for being my mentor and my entire team at Medica. And last but not the least, the patients who gave us consent to perform this study. Thank you.
I just had a quick question. Of the patients who had a false negative lymph node mapping, what percentage of those patients would it have made a difference to the ultimate treatment?
Only 1 was false negative of the full.
And did that affect the ultimate treatment?
Not really.
Yeah, very excellent study. Congratulations for the good result. And in an NCCN guideline and the FIGO staging system, both recommend to evaluate para-aortic lymph node for high-risk endometrial cancer. Did you evaluate para-aortic lymph node in this patient? It's my first question. And the second one is, during surgery, when you take out enlarged lymph node or sentinel lymph node, did you send it for frozen biopsy or not? My third question is, what kind of preoperative imaging did you perform? Is there any inclusion criteria based on preoperative imaging, especially for lymph node size?
Actually, for inclusion criteria, come to you first. For stage 1 and 2, we sat with the radiologist prior to it with the MRI images, and we located the depth of invasion of the uterus and all. According to that, we also did the CCT whole abdomen C to localize any nodes are there or not. After that, only we included the patient in inclusion and exclusion according to criteria. And your second question, sir?
Regarding frozen biopsy,
we did ultra-staging for a sentinel lymph node.
Okay, how about para-aortic lymph node evaluation during surgery?
For high-risk cases, if a sentinel lymph node, first we did that sentinel lymph node. In case where we didn't define the sentinel lymph node, we went for a total lymphadenectomy for those cases. For para-aortic evaluation, you're saying, we went to para-aortic for the high-risk cases as well.
Thank you, Dr. Saumini. Thank you all the judges, Dr. Yogesh, Dr. Joseph sir and Dr. Park.